Assalamu alaikum, good afternoon. I would like to thank the Society for the kind invitation. So shifting gears from upper GI to common anorectal disorders. I have no disclosures. I'm going to talk about the most common three perianal conditions that we face in the clinic on a daily basis. I'm going to talk about hemorrhoids, perianal fissures and perianal abscesses and fistulas, and anal fissures. We'll start with hemorrhoids. So hemorrhoids are part of the normal anatomy of the anal canal. They are considered as vascular cushions, and they contribute to 10 to 15% of the continence mechanism of the body. The dentate line corresponds to a line of anal valves that represents a remnant of the proctodeal membrane. You can see here that the yellow saw-toothed line represents the junction between the ecto and endoderm. This has a significant implication in treating patients with anorectal disease, and even though in patients with malignant disease as well. Let's focus here on the management of hemorrhoids. So patients who have internal hemorrhoids which are located above the dentate line, these patients can be managed with office-based treatment. The reason for that, because the innervation of the area above the dentate line is from the autonomic nervous system, so it will be only sensitive to stretch. Some of the office-based treatment can be applied in these patients. However, the area below the dentate line, which is the origin of the external hemorrhoids, are sensitive to pain, touch, and temperature. When the patient is placed in prone jackknife position, which is the place where we operate on these patients, you will find that the external hemorrhoids are located in three classic quadrants: the right posterior, the right anterior, and left lateral quadrant. Again here, the hemorrhoids can be classified into internal and external hemorrhoids, and that is based on the location in relation to the dentate line. The internal hemorrhoids are located above the dentate line, whereas the external hemorrhoids are located below the dentate line. This is a classification scheme for the internal hemorrhoids. So class 1, when the internal hemorrhoids bulge into the anus without any prolapse. In grade 2, when the internal hemorrhoids prolapses during defecation, however, it's spontaneously reduced, the patient will feel that there is something prolapses outside, and it will be reduced by itself. On grade 3, the internal hemorrhoid prolapses. However, the patient by himself will tell you that he have to push it back to be reduced. And in grade 4, when the hemorrhoid prolapses and doesn't reduce back. There are precipitating factors for hemorrhoid. Any cause that increases the intra-abdominal pressure or straining will be a precipitating factor for hemorrhoids. That includes pregnancy, chronic cough, prolonged standing, and excessive straining. At the molecular level as well, there are some changes. So there are studies that have shown that from the hemorrhoid specimen, that the matrix metalloproteinases has been shown to be overexpressed in these samples. The metalloproteinases are enzymes that are responsible for breakdown of the elastin and fibers, and this can contribute even to the prolapse of the internal hemorrhoids. In addition, further studies have shown that in these hemorrhoidal cushions, in symptomatic patients who require surgery, the vascular endothelial growth factor and the endoglin, which is correspond to the CD105, has been increased and overexpressed compared to normal samples. Patients with hemorrhoids can present with rectal bleeding, prolapse, and mucus discharge. However, these are mainly prominent symptoms for internal hemorrhoids. Usually the hemorrhoids, either internal or external, are painless. However, when a patient comes in with pain due to hemorrhoids, it is either a thrombosed external hemorrhoid or grade 4 internal hemorrhoid, which is the one that it prolapses outside and it is not reducible. Itching is a symptom of internal hemorrhoids as well, especially if it is prolapsing outside, because of the mucosa is prolapsing outside, it will continue to secrete the mucus, and this will cause severe irritation to the patient. Physical examination is extremely important because a lot of anorectal pathology can be diagnosed by only inspection and digital rectal examination. So fistulas, abscesses, and fissures can be diagnosed in addition to thrombosed external hemorrhoids and suspicion of anal cancer as well. Digital rectal exam is extremely important, and when it is done, it should be assessed for masses, sphincter tone, and tenderness. I just wanted to highlight the sphincter tone because it will dictate how we can manage this patient. If the patient has a decreased sphincter tone to begin with, this patient might not be benefit or a good candidate for a hemorrhoidectomy. Otherwise, he will not be a happy patient. In addition, anoscopy and rigid and flexible sigmoidoscopy to complete the workup in the clinic. So do all patients with hemorrhoidal bleeding need a colonoscopy? A young patient with a typical outlet bleeding that responds to treatment with no red flags, no family history of colorectal cancer, there is no need for a colonoscopy. So let's track this back and define what is outlet bleeding. Outlet bleeding is bright red blood per rectum during or after defecation and found in a toilet paper with no family history of colon cancer or colorectal cancer, and without any evidence of change in bowel habits, no alarming symptoms, no abdominal pain, and nothing else. In addition, that if you treated the hemorrhoid and the patient stopped bleeding and became asymptomatic, then you would say that you wouldn't need a colonoscopy. And this is the paper I'm referring to answer the previous question. So this is a paper from Cleveland Clinic. This is done by Church and his group. Looked at the classic outlet rectal bleeding in patients who are less than 50 and older than 50. And they found that patients who have classic outlet bleeding who are younger than 50 had an adenoma of less than 2% and no cancer was identified in that cohort. However, patients who are more than 50 obviously had a higher significant risk of detecting other pathologies such as cancer and dysplasia, reaching up to 7%. So the whole message of that, if the patient is having any of the red flags, regardless of age, they should be screened. The treatment of hemorrhoid can be classified into medical management, office-based treatment, and operative therapy. All patients with hemorrhoids should be advised to start on high-fiber diet, and they should be given stool softeners and encouraged to drink adequate fluid intake, sitz bath. And all of these are an attempt to decrease the incidence of constipation and have a normal bowel movement without excessive straining. There are a lot of over-the-counter medication, especially in North America. Whenever you go to a pharmacy, you will see tons of medications, topical creams for hemorrhoids. These usually work temporarily, and there's no class 1 evidence to say that these are effective. Most of these patients will use it and end up in your clinic complaining of the same problem. Let's start with the most common office-based treatment that we do in the clinic. We have a couple of options: rubber band ligation, the energy ablation, and sclerotherapy. Let's start with the rubber band ligation. So the rubber band ligation is applied to the internal hemorrhoids, which are located above the dentate line. Usually the internal hemorrhoid pedicle is grasped, and then the applicator is, we apply the rubber band to the base of the hemorrhoid. How this works? So by applying this rubber band at the apex of the internal hemorrhoid, the hemorrhoid is fixed high into the anal canal. And this will correct the prolapse in grade 2 and grade 3, and thus will lead to decrease in the blood flow, and the hemorrhoid, consequently, it will shrink in size. However, this is contraindicated in patients with bleeding disorder or anticoagulation. because with the rubber band ligation, classically, the patient will form a scab after 5 days, and the scab will fall off like a wound. And then in normal patient, they will bleed a bit, and usually we tell our patients about all that. In patients who are on anticoagulation, or if they have a bleeding disorder, they will not stop bleeding. They will continue to bleed. So this is a contraindication to place a rubber band ligation. Luckily, the complications of rubber band ligations are low. However, it might lead to serious problems. So as I mentioned, delayed bleeding, it can happen. Urinary retention, it can happen in elderly gentlemen, especially if you're applying more than one rubber band ligation per session. One of the fearful complications from rubber band ligation is pelvic sepsis. It is rare, however, when it happens, it is a major problem. The patient typically present after 3 to 5 days from the rubber band ligation. They will present with fever, urinary retention, and increasing pelvic pain. And usually these patients will require an examination under anesthesia in the operating room, debridement of the wound, and possibility of laparotomy and even colostomy in some situations. Other office-based treatment, as I mentioned, is the energy ablation. Infrared photocoagulation, bipolar dithermy, or direct current electrotherapy. The most common one of these is the infrared photocoagulation. So the infrared photocoagulation work in a similar mechanism. The infrared radiation generates heats that coagulate the protein and creates an inflammatory bed, thus leading to ischemia and lead to scarring and fibrosis, and thus will decrease the incidence of prolapsing hemorrhoid. It indicated for grade 1 and 2 hemorrhoids. However, it is associated with pain and bleeding. And in comparison to the rubber band ligation, it is painless. So with the infrared photocoagulation, a patient might have pain after the procedure. Let's talk about sclerotherapy. So the sclerotherapy is a solution that is injected into the apex of the internal hemorrhoid and lead to scarring and fibrosis and fixation as well. So all work with a similar idea with different mechanisms. A couple of agents can be injected into the hemorrhoid and can include the phenol and the sodium monorate. And this is how it is done. So the most symptomatic internal hemorrhoidal complex is identified, and then a submucosal injection is done using a spinal needle to the affected area. The mechanism of action here is that the sclerotic agent will cause a fibrosis or fibrotic reaction right away, rather than sloughing. The sloughing happens with the rubber band ligation. However, with that injection, it will induce severe fibrotic reaction right away. And because of that, it can be safely used in patients who are on anticoagulation. You remember the reason why we couldn't use it in patients who are on the rubber band ligation on anticoagulated patient? Because of the scab formation that will form, which will fall apart after 5 days and the patient will bleed. However, with the sclerotic agent, it will cause fibrotic reaction right away, and there is no scab to form. So that's why it is safe to use it in patients who are on anticoagulation. So it's not the first line of treatment, as I mentioned. It is used in grade 1 and grade 2 internal hemorrhoids who are taking anticoagulation. And personally, because of its complications, I prefer to stop the patient from anticoagulation for 5 days, do the rubber band ligation, and start the anticoagulation within 2 to 3 days. However, this is an alternative approach. If the injection is too deep, it might cause a perianal abscess or ischianal abscess and severe pain. If it is too superficial, it will cause mucosal sloughing. In addition, urinary retention can happen. Operative therapy. So it is indicated in patients who failed medical treatment, or if the symptoms are recurrent or persistent symptoms. And just to highlight that only 5 to 10% of patients with hemorrhoidal complaint will really require a surgical hemorrhoidectomy. There are different techniques. However, the most common is the excisional hemorrhoidectomy with the closed technique. And this is how it is done. The hemorrhoidal complex is identified and dissected off the sphincter muscle, and then the incision is closed. Complications, it includes urinary retention, postoperative bleeding, anal stenosis, fecal incontinence, and postoperative infection. Most of these are preventable if we did an adequate examination and listened to the patient and took an adequate history, and the technique was excellent. Let's start with anorectal abscesses and fistula. Let's start with the anatomy, because there are different spaces where a patient can present with anorectal abscess. So the perianal space lies immediately around the anus or the anal verge, with a medial extension to the dentate line and extend laterally to the subcutaneous fat in the buttock. And this is the most common, luckily this is the most common type of perianal abscess. Ischianal fossa, it's the pyramidal shaped space which occurs between the perineum and the levator muscles. The supralevator space, which is located above the levator muscle and close to the rectal wall. And this is a different figure showing how deep is the supralevator space in relation to the other spaces. The intersphincteric space, which is the space between the internal sphincter and the external sphincter muscle. The importance of what I'm saying is that only in the first type only that space, the perianal space, where the patient can present with perianal pain and the clinician can see it on physical exam. However, the last three potential spaces that I've mentioned, the patient comes to the emergency room with perianal pain, they got examined, and the patient, and clinically they don't have anything on the physical exam. There is no redness, there is no erythema, only continuous pain. So these patients should be imaged to diagnose these conditions. The etiology of anorectal abscesses are coming from anal crypts, which are considered the primary source of the development of perianal abscesses. The cryptoglandular theory is the most common theory for development of abscesses, which is obstruction of the anal crypts by a foreign body or a perineal debris that lead to stasis and obstruction. Some of the predisposing factors include smoking, trauma, and liquid stool entering the anal ducts. We have a long list of causes of anorectal abscesses. However, as I mentioned, the cryptoglandular theory is the most common. However, we shouldn't forget that TB, leukemia, lymphoma, and inflammatory bowel disease, mainly Crohn's disease, can be one of the major contributing factors. As any abscess, they present with acute pain, fever, malaise, and locally they will have induration, swelling, fluctuance, and erythema. Not all patients with perianal abscesses should be imaged, only in patients who have recurrent or incompletely drained abscess or patients with Crohn's disease. The management of these should be by incision and drainage close to the close to the anal verge. And as you can see here from the picture, the incision and drainage should be as close to the anus with a cruciate incision, and make the incision wide to achieve adequate drainage. Complications include bleeding, urinary retention, and recurrence. I will jump into anal fissures. It's a tear in the epithelial lining of the distal anal canal. Usually present with very sharp perianal pain and bleeding, and on physical exam you'll see linear separation of the anoderm. It can be classified as acute versus chronic, depending on the duration. If it is less than 6 weeks, it is acute, otherwise it will be chronic. Typical versus atypical, the location usually anterior or posterior. However, if it was on the side or laterally, these are atypical and it could be TB or Crohn's disease. The last two slides, the initiating factor is microtrauma of the anoderm due to constipation and hard stool. This will lead to a wound, and that perianal wound will lead to severe perianal pain that lead to sphincter spasm, and that spasm will lead to increasing the pressure in the anal canal, leading to decreased perfusion. To treat the condition, we have to break the cycle. Otherwise, the patient will not get healed. So we have to treat these factors to enable us to reach complete healing. So we'll start with stool softeners, sitz bath, pain control. In addition, to treat the sphincter spasm, we have to relax the muscle. Relaxation of the muscle happens from topical agent or Botox injection or surgical sphincterotomy. The medical treatment will be calcium channel blocker. This is the most common medical treatment to start with. Nitroglycerin can be used, however, it is associated with severe headache, and most of the patient will stop it from the first week. If the medical management failed, we'll go ahead with botulinum toxin, and this is what you call chemical sphincterotomy. The last slide, if the medical management failed, then the anal sphincterotomy will be achieve healing for these patients. Thank you.